have a extremely varied agenda on this policy forum. I think there's something here for just about everyone. If you can't find it, then maybe you're not looking hard enough, because there's a lot of issues here that we'll be addressing over the next couple days. I just wanted to introduce myself. I'm Tom Sherry. I'm the president of CBHDA, and I also am the Human Services Director for Sutter County, and we have a bi-county mental health program that includes Sutter and Yuba counties. And as I was looking through the agenda, I noticed a couple particular areas that's sort of fond to Sutter and Yuba counties. We have the agenda includes cultural concerns, spirituality, and integration with primary care. And although we're small counties, there's about 170,000 total population. Of that population, there's about 3,000 Hmong individuals in Yuba County. And that population we were having difficulty connecting with, and connecting them with primary care. We then, back in 2009, took a trip down to Merced, who had a program that helped integrate traditional healers into the hospital system. And we thought that was a grand idea. So we started on the same type of project, and we've been able to work with not only our hospital system, but a number of the other emergency clinics around the area to have traditional healers come in and do traditional healing with the Hmong population, and also to sort of make them more comfortable with the primary care side of things. We had set up tours with the shamans and the leaders of the Hmong population, and toured like the surgery centers, the radiology programs, the cancer treatment centers, the emergency room, so that the elders in the Hmong community and the shamans would become more familiar with leaders in those particular programs and departments. The result is we have in our hospital a policy for automatically approving traditional healing in the hospital for at least 10 different types of traditional healing. And of course, if there's additional types of traditional healing that would have to be provided in the hospital is open to working with the Hmong leaders on that. So this is a project that has been operating since 2010, and I thought it was something that I'd like to share with you about how a small county was able to work with their community partners, both on the primary care side and in the Hmong population. It's probably something that we should look at, not just for the Hmong population, but for our own populations, and how we can integrate more spirituality and traditional healing within our communities. So this will be an interesting conference for me and policy forum, and I look forward to learning more things about different ways to approach services for all of our clients. Anyway, I wanted to then turn this over to Al to introduce himself and a couple comments.
Shall I take it from up there
Sure.
or down here?
No, go ahead.
Good afternoon, everybody. My name is Al Senella. I'm the president of the California Association of Alcohol and Drug Program Executives, big name, otherwise known as CAADPE. Also the president and CEO of Tarzana Treatment Centers. I would just like to touch on a few things that I think are connected with the theme of this particular policy forum around partnerships. and talk a little bit about some discussion that the CAADPE board had earlier this year. We see a lot of mergers going on and a lot of talk about mergers, and the CAADPE board had met early in the year talking about that subject, asking ourselves, should we consider merging? Should we consider redefining who we are? Many of us are mental health providers, as well as some of us are primary care providers, and does our focus on SUD still make sense in today's world? And I think unanimously the board felt that our focus was more important than ever on the subject of SUD services, because we feared and to some extent have seen that voice getting smothered with a lot of the changes that are going on, at least in some regards. At the same time, I think that there's lots of discussion when we talk about integration of primary care, mental health, and substance use. That discussion often goes on within our own silos, because I think we still have too much silo thinking going on and a lot of mistrust that still exists in the various fields. And I think that mistrust and that silo thinking interferes with developing effective partnerships. I think we can all do a lot more to break down that silo thinking and open doors and create new opportunities for partnering. I think that a number of the mergers that are taking place both create new opportunities, but also have risks associated with them. Thinking is different sometimes with those mergers. Different personnel are involved. Old partnerships may end, and hopefully new ones would begin, but sometimes those old ones are important, and there should be consideration for maintaining them, and some of us have observed that may not always be the case. I think that forming partnerships is easier to do if we focus on the collective target, and I think that collective target is our shared patient. I mean, we're all serving in large part the same individuals that need services in these different domains. And if we focus on how best to impact their lives rather than what can the partnership do for me or do for us, I think we might get more progress in that area. Not that there hasn't been a lot of progress in that area. I think partnerships are often driven by financial considerations. I think they're often limited, sometimes advanced by those financial considerations. But I don't think finance has to be part of a partnership for a partnership to be effective. I think there are a lot of partnerships that go on without dollars and cents being in the mix in terms of subcontracting or purchasing of services kind of thing. And so I think we should keep that in mind. I want to touch on some things that I think concern the SUD field in a significant way. And I think they're largely driven by, I don't know, maybe knee-jerk reactions to some degree over past scandals, if you would, in the drug Medi-Cal world. But I think that some of the recent regulations cause some heartache when it comes to the discussions of partnerships. There continues to be a significant amount of stigma, both for mental health as well as for SUD. But I think that the stigma around SUD perhaps in today's world might be worse in some regards. It certainly is administratively. When we see things about let's designate the entire community of providers as high risk, regardless of whether or not they're an outstanding provider, it sends to me a wrong message to the public, to the community. I think to others that you might want to partner with, well, wait a minute, you're one of those high-risk people, maybe I don't want to get into bed with you with any kind of partnering kind of thing. I think things about singling out somebody who's a Medi-Cal recipient who goes to a group and having to have that individual sign in to participate in that therapeutic activity while everybody else that's not a drug Medi-Cal patient doesn't have to go through that sort of process, again, sends a mixed, a bad message to me, to the public, to the community. I also have had a strong position, the association has had a strong position over the whole workforce issue with counselor certification, and I see it getting worse rather than better as entities that used to be in the certifying business are eliminated because they're not meeting certain standards. There is, to me, a continued strong need for a single state agency to take on that role and bring some true credibility to that element of the workforce. And I think I'll shut up now and pass it on. Thank you.
Good afternoon. My name is Steve Elson. I'm the current president of the California Council of Community Mental Health Agencies and also the CEO of Casa Pacifica Centers for Children and Families. We're in Ventura and Santa Barbara counties. We have CCCMHA, has about 70 members and growing, and about 2/3 of those members serve children. About 1/3 of them exclusively children. And this is going to be my last opportunity. I'm going to hand the gavel over to Daryl Evera of EMQ later this week. And so I do want to say something about children, since I don't hear a lot about kids, so I'm going to do that. And I'll do it by way of, there's a story about a psychologist who was a professor at a local university, and he loved to do weekend projects, and so he was out in his front yard putting in a new sidewalk. So he had the cement all smoothed out, fresh cement, and a bunch of kids in the neighborhood came by and noticed it and started to write their initials in the cement, and he sees them from inside his house sitting at his kitchen table, and he runs out and chases them off. He's irate, he swears at them, he can't believe what's happened to his sidewalk. Comes back in and his wife said, "Honey, what's going on? I thought you loved kids." And he said, "I do, I love them in the abstract, not in the concrete." But those of us who serve kids love them in the concrete. We put our work and that abstract notion into Levi's, and we believe that the best investment you can make in mental health is investing in children. That's the best preventive strategy I can think of. And on the issue of integration, it's something that I think we all struggle with. We certainly do. We have our agency has a primary care clinic as well as a boatload of mental health services, both on our campus, which provides residential treatment, as well as throughout the community in both Santa Barbara and Ventura County. And I heard on a webinar, and I've heard from Open Minds, the webinar actually was a National Council webinar that Tarzana, I think, was leading, and I heard, I don't know if it was Al, but it was certainly somebody on your staff, Al, who said to get integration, to actually have integration between primary care and behavioral health care, you've got to have an integrated treatment plan. In your electronic health record, you have to have a single treatment plan that includes both health care and behavioral health. And as I mentioned, we have a primary care clinic, and yet we struggle internally. We still don't have a single treatment plan between primary care and behavioral health care for the kids that we serve. That is a priority. We hope to be there in the next few months. But this whole integration thing, is a huge issue, and we're really delighted that this conference is going to address that issue, and we're looking forward, I think all of us on the private side are looking forward to seeing some solutions to that very knotty, K-N-O-T-T-Y, naughty problem. So thank you.
Good afternoon. My name is Peter Currie. I'm a child and adolescent psychologist, and I have a strange employer. I work at a health plan. Health plans aren't known for knowing a whole lot about behavioral health. So it's given me a lot of opportunities over the last 5 years to try and bridge that gap between medical and behavioral health. And so nothing like the last year. We've had one integration project after another, and I just wanted to emphasize some of those and maybe give one as an example and hopefully underscore what I believe is our primary task, which is to bring health plans up to speed because they have to integrate behavioral health at this point. It's no longer out for the jury. They are getting the responsibility as we speak, and they have to learn what you all know about taking care of the behavioral health needs of members. So I'd like to echo some of the things I heard earlier. I think we have to be on a common care plan. It's really good to hear that, and I think the health plans have a lot to offer in that regard, so I hope we head in that direction. There have been a series of new responsibilities that have been downloaded to the health plans this year. The first, in January, we got Medi-Cal expansion. I, for one, spent the first 6 months of the year digging out under a landslide of members accessing mental health services that they didn't have access to before. In the first quarter, just in my health plan, I authorized about 24,000 outpatient mental health visits for Medi-Cal members that didn't have that benefit before. This is exciting. This is exciting that people that didn't have access to psychotherapy, to psychiatry, to just basic mental health services got it this year. And health plans got that responsibility, so we had to dig in and figure out how to deliver that care. And it also drove us to collaborate with our county partners. I think I've seen my county partners at least once a week for the last 8 months. I see them in the room here. Having the benefit has forced us to build on the relationships that we've had before and make them a working relationship that becomes part of our everyday routine now. That's new. Then in April, we got the CalMediConnect launch. So we're one of those health plans that has all the duals rolling into the plan starting in April. So I'm getting a download, and it'll triple my dual population by the end of the year. So we have all the responsibility for behavioral health in this population, inpatient, outpatient, all levels of care. But many of these patients are already embedded in the county mental health system. So again, we have to build collaboration and ways of working together to make sure these members that are getting care in the county system are not dislodged because now there's a new payer involved. So that was number 2. Number 3 came on Monday. This was a whirlwind, and that was the new autism benefit that came to the health plans. So again, some of the people I've been working with know I've been working on this for a couple years in our 2 counties, and fortunately, we've been preparing, even though we didn't have the benefit, but we didn't anticipate we'd get it overnight, and it did happen overnight. And most health plans are still looking today, trying to figure out how they're going to put together a network and respond to this. But that didn't change the will of the state. The state's going forward. We are implemented, and as of the 15th, we as a health plan are paying for ASD services. I'm personally very excited about it. I don't think change that's needed oftentimes comes over a long period of time. Sometimes it comes in a landslide, and we have to learn how to digest it and respond to the population's needs. So one of the things that we did with this latest is I have to educate my health plan, everybody in it, member services, IT, everybody that works in this health plan about ASD. What are the needs of this population? That's really the first step, because if we're going to manage the benefit, then we better well know who the population is that we're serving. And that's really my point, is that any of these new downloads of responsibility, I think we have to look at right down to what populations, groupings are there in this populations. ASD, autistic children, is a complex population with complex needs. And so it isn't something that you can simply just start doling out visits next week and call it good. You have to understand, first of all, what that population looks like. So for the last couple of years, we've looked at it in the Inland Empire to see what this population needs. And if I can get it to advance, this is the core of the problem that we found. When we looked at it from regional center to county mental health to education, we all dug in together in a collaborative and looked at this population with the Autism Society and discovered that really we have a huge problem in disparity, and that children in the Inland Empire aren't diagnosed until the average age of 5. Nationally, it's age 4. So already I've got a year of lost early intervention with this population in my community. That's not acceptable. But we dug in further and we found out that it's all the way to 7 years of age for the average diagnosis to be made for autism for Latino children. And that's definitely not acceptable. So part of the job of the health plan and all of you is to figure out what this population needs, what they're missing. Obviously, we can't start a treatment plan until we get them diagnosed and identified. So that's the foundation. We have to figure out how to do the outreach and identify these children. So I want to play you a video. This is what I sent out to all my staff. There are about 1,200 in the health plan last Friday, to try and prepare them for the kind of callers that we're going to have on Monday. And this is where I think we need to start when we look at a population. Let's go back to the people we serve and figure out what they really need. So let's play this video real quick.
Autism spectrum disorders are a complex neurodevelopmental disorder characterized by social impairments, communication difficulties, and restricted and/or repetitive behaviors. Autism knows no racial, ethnic, or social economic boundaries. Everyone is affected, and right now 1 in 68 children are being diagnosed with autism. We still don't know the cause of autism, but research shows that early intervention can greatly improve a child's development. Early diagnosis is critical, but often is delayed. Autism can be diagnosed as early as 24 months. However, most children are not being diagnosed until after age 4. And minority children are frequently diagnosed after age 6. These numbers are reflected in the Inland Empire as well, where there is a shortage of trained personnel and a fragmented system in which diagnosis and treatment are not understood or coordinated. Parents in the Inland Empire will often recognize developmental differences with their child and then share their concerns with physicians, falling on deaf ears. There are daily stories shared by frustrated and weary parents who are not able to get help for their children. Listen as families share their thoughts of time wasted and their voices not being heard.
At 10 months old, he started losing focus. I would look into his eyes and he looked lost, or he would turn his head away and refuse to look at me. When he wasn't walking or talking by his first birthday, the thought of autism flooded my mind. At his 1-year physical, I remember asking the doctor if my son might have autism. I shared some of the odd traits and lack of milestones. She told me to stop worrying and stated, "Every child develops at their own pace, and boys are generally slower." When he was 18 months old and still not talking, I took him back to the doctor. This time she said, "It's unusual he isn't saying simple words," but she still didn't think it was autism. She said, "Autism's a fad diagnosis, like ADHD in the 90s. She told me, "Wait until he's 2, and if he isn't talking by then, we'll explore other options." Looking back, I wish I would have put my foot down and demanded help. I knew something was wrong. I waited until he was 2, and she finally gave us a referral, reluctantly. In an evaluation that lasted about 5 minutes, it was clear that my son did not understand what was being said to him and didn't care. He was in his own world. But this reaction from him still did not deem a diagnosis of autism. They suggested bringing him back at age 3. Finally, at age 2 years, 10 months, he was truly evaluated. This time, it was an hour-long evaluation with a lot of questions, test scores, and an interaction with him. That same day, the psychologist emailed us his diagnosis. It was autism. It had taken 2 years to get the diagnosis.
I really tried to hold it together as I explained to my son's physician that at the age of 5, my son couldn't dress or undress himself, couldn't toilet independently, had meltdowns at the side of a bathtub, couldn't use utensils or drink from a cup, and paced up to 2 hours a night. He had language delays and was socially challenged. I knew it was autism, and I wanted behavior therapy for him. I was told, "These are all occupational therapy issues, not autism. Why would you want behavior therapy?" I explained that I had done extensive research when one of the doctors commented, "This is the problem when parents do research on the internet. ABA doesn't work for everyone. It's very repetitive, like dog training. Do you really want a therapy for your child that they use for training dogs?" When he said that, I thought, he doesn't know autism at all.
What could it have cost to put an early screening for autism leaflet in my baby folder? You know, the one I was given upon release from the hospital along with all the formula coupons?
I was so conscious of the clock ticking away and the wasted time that could have and should have been used to provide needed services to both my kids. I just couldn't see the reason for parents having to fight to get services that are clearly meant to be more readily available. Some days I just want to stop fighting everything, but then I see the progress they've made and I realize I'd do anything to help them.
The progress has been amazing in the year since receiving behavioral therapy. It was worth the fight, but I often wonder, why was all the struggling necessary? I still get angry when I think of everything our family went through. I wonder where his skills would have been if he received services when we took him in initially. I wonder what additional skills my child would have if only the doctors could have been more receptive to my concerns and constant requests for help. It's difficult enough as a parent to raise your hand and say, "I think there may be something wrong with my child. I don't know why or how to help him. What should I do?"
It's understood that intensive, well-designed, and timely intervention can improve the quality of life for many children with autism and their entire family. Early and appropriate intervention may be the key to greater independence, increased participation in the community, and ultimately achieve a more productive and fulfilling life. But without an accepted diagnosis and coordinated efforts, a child may not receive the imperative and intensive interventions needed. Your help today can be the future for our children tomorrow.
So I played this just to emphasize we have to go back to the people we serve and understand their needs and then try and reinvent ourselves around those needs. And that means creating a new collaborative. Autism is just one population. I wanted to use an example because it's hitting all the health plans today. And they're going to need input from all of you as to what you know and what you could bring to the table to help these children. Right now, I think the answer for these kind of populations is creating new collaboratives. It's real clear to us in the Inland Empire that we're failing these children because we're trying to treat them in silos. These children spend years going from one assessment to another, trying to piece together a treatment plan. Why can't we as professionals come together around those children and bring the assessment to them so we can get early intervention started? That takes getting out of our silos and starting to collaborate, which I think is a theme of what this conference is all about. Creating new partnerships, and particularly looking at how do you create a partnership with the health plan. They have access to those PCPs. They're their payer. So they're good leverage to be able to leverage medical personnel to help populations like this, to bring neurologists, geneticists, all those other rare resources to bear for this population that none of us are going to be able to treat adequately in any one of our silos. So that's what I'd like to challenge you today, is to think in terms of who we serve and how to collaborate more effectively.
Thank you, Peter. I thought that was just a beautiful, just kind of clear picture of what we need to do, starting with very young children. I can't tell you how many people I've talked to with very young children who can't get a diagnosis, who can't get the help that they need, including some very close friends. And I just, we did a legislative briefing last week. Sorry, I should introduce myself. Sandra, Naylor, Goodwin with the California Institute for Behavioral Health Services. Thank you. But I do want to share a story that Senator Jim Beal shared with us at this legislative briefing. And I hadn't heard his story before, but it was very similar to the videotape, where he had a young child who, for a variety of reasons, suffered some brain damage, and then he was unable to get help for that child. He kept talking about how parents of special needs children are punished, not helped. And as a senator even, he searched everywhere to try to get help for that child. He finally was able to do it, but not without a great deal of effort, a great deal of pain that he and his wife had to go through to get that help. And then when the child became an adolescent, late adolescence, he developed schizophrenia as well. So now he's fighting with the mental health system, and we're not doing a heck of a lot better in responsiveness to him. And I'm thinking to myself, if a state senator can't get the help he needs, what about the rest of us? It's nearly impossible, and I thought your videotape really illustrated that beautifully. So this particular policy forum, we're focusing on healthcare reform and the fact that it does take partnerships. I thought that the video clearly laid that out. Certainly our other presenters this morning have laid that out. And I will say that for us at CIMH, we were CIMH, California Institute for Mental Health. We had been partnering for a long time with the Alcohol and Drug Policy Institute. And then last March, both boards took a vote to merge, and we've done that actually quite seamlessly. And it's been wonderful working with Victor Kogler from ADPI. In fact, about 2 weeks ago, we did a 3-day intensive seminar for all of our staff on substance use disorders. We have some folks who are already very well versed in that, but most of our staff have been so focused on mental health, it was very helpful to have that 3-day seminar to really get people up to speed on what we know about substance use disorders. And out of that, we kind of thought, boy, the one thing that's really critical, if you want to be a partner with another organization, you need to know them. You need to understand who they are and what they do, and how what they do can complement what you're doing. And we've been doing these learning collaboratives around care coordination, where we have the mental health team, substance use team, primary care team, and now very often the health plan there as well. And sometimes people are amazed and shocked at the number of people that they share, who are going to all these services, but they didn't know it. And I'll tell you, the one thing that sort of blew me away, and I think everyone else in the room, was when they did the medication reconciliation and discovered what kinds of things this one individual was being prescribed that the others didn't know about. And that often they were not just not necessarily working well together, but they were often contraindicated, and we were actually doing more harm than good. So that was a real wake-up call, that we've got to work together. We've got to develop collaborative relationships, partnerships, whatever you want to call it, but we've got to work together if we're going to do a good job of helping people with these variety of needs. And most of us don't come with just one, right? We come with multiple issues that we need to deal with. So I hope this policy forum, our design was kind of to help people understand each other a little better. That's what we're hoping for. And hopefully maybe you'll have the chance to even talk to folks and get to know them a little bit, so that as you work on these partnerships, it's someone you know, and you have a good understanding of what it is they do. And we've asked our presenters, all of them, to not just talk about the challenges they face, but where they found solutions, to share those solutions so that you've got something to go home with and to think about how you can make that work for yourself.